Okay, I understand there are many interesting discussions going on. I'm sorry I have to stop you there, but there will be opportunities to continue. And I now really want to introduce you Professor Paul Worley. He has been acting as a dean at the Faculty of Medicine at the Flinders University, and today he is serving as Australia's first rural health commissioner, and he's a general practitioner who is running, in addition to all his mandates, a practice, as I understand. Today he will really talk about a very interesting project because he and his team, they managed to bring a whole degree program into a very rural, or into many very rural sites. Paul, the stage is yours, or better, the wall is yours.
Thank you, Christoph. Firstly, can I ask everyone to put their hands up in the air? That proves that you can hear me. Thank you very much. That's wonderful. So I'm speaking to you today from Dublin in Ireland, where I've been a participant in the WHO Global Forum for Human Resources for Health, an issue that's very passionate for me because it speaks about the equitable access to healthcare that many people in our world don't get. And can IT and technology in general be part of the solution? So let me paint a scenario for you. Imagine that your medical school or your nursing school or your allied health professional school stretches from Boston, Massachusetts to Houston, Texas. The combined land mass that you serve is 4 times the size of Texas, but has only 2 million people. Part of the region have life expectancies equivalent to sub-Saharan Africa. There are severe doctor shortages outside your capital city. You have a moral obligation to do something about this, but you are stuck in a relatively wealthy suburb in a very comfortable city. The evidence says that you can't change this unless you get your hands dirty. And by that I mean engage in teaching and research in the under-resourced regions you wish to serve, recruiting students from them and establishing flourishing academic cultures in their health services. You can't replicate your full academic infrastructure in a town of 5,000 people. So you need another solution. This was Flinders in 1997, and enter stage left, the distance learning department with its photocopiers, faxes and videotapes. Yes, in 1997 we did not have the sophistication that we have now and that I was hearing Diane talk about in terms of the technology or the data analysis, even the networks that we have now, as poor as they are in many rural areas, are so much better than they were back in 97. Even though we had those deficiencies, we were able to make significant changes. What have we discovered? We've discovered that you can start very simple. We started by piloting, essentially piloting between Boston, Massachusetts and Portland, Maine. So a smaller distance to pilot our technologies and our approaches. Whereas we have a lot of web-based intranet, synchronous video conferencing, including teaching anatomy synchronously by video conference, asynchronous lecture distribution, all of those sort of things. We didn't have those at that stage. So we used simpler technology. And we found that as long as you had reliability and that you had redundancy in your system, then things worked really well. What we also found was that the clinicians in these rural communities where our students were learning used the equipment for their own education and their own clinical purposes. So there was a win-win between the university sector on the one hand and the health sector on the other. What we found in that period of time, and as I said, we started Boston to Portland, and then we actually distributed our course over the whole of the 3,000 kilometres between Adelaide in the south of Australia, on the south coast, to Darwin, on the tropical north coast of Australia, we found that not only can you do it, but students do really well. Students have had profound academic outcomes as a result of learning in context. And more than that, it's had a meaning to them that the IT has enabled. It's enabled it by enabling them to stay in communities long enough to become part of that community while they're learning to become a doctor. That then translates to career outcomes, where these doctors preferentially choose primary care, rural practice as their career. They don't only choose that. We've had neurosurgeons, we've had radiation oncologists, we have pathologists come out of our program. But preferentially, there's a 17 times odds ratio for the students who have been in our rural and remote learning locations to choose rural practice compared to students who learn in cities. If you look at the United States, where do the majority of students learn their clinical medicine? It's in big cities. So there's an issue here that across the world we need to face. The IT enables students to be there for long enough to overcome what I call the medical tourism honeymoon period, where everything's fantastic, being in a new place. They also need to be there long enough, though, to overcome the next stage, which is the depression of the overwhelming problems that you'll never be able to solve in many remote communities, particularly in Australia if you're dealing with Indigenous communities or in America, Native American communities. And you need to be there long enough to emerge into the agency period. And it's the IT connectivity that enables students to stay there long enough without being isolated from all the resources of the university. It also enables them to be valuable to patients. Because they're there long enough, they can become part of the team. Again, it's not tourism, it's actual real work that IT is facilitating. So we're therefore benefiting the clinical services while we are delivering education in rural and remote areas. For us, this has opened up a whole lot of new clinical learning venues, which not only have enabled our existing students to learn differently, but we've actually been able to recruit more students into the school. And at Dublin at the moment, that's one of the big issues. How do we scale up clinical education? Part of that way of doing that is actually enabling all of our clinical venues to become learning venues, to become part of an academic health science system. And IT connectivity can enable us to do that. Yes, we've used simulation. That's been important for the learning of procedures, and as the last 20 years have gone, our simulation has become far more sophisticated. We now are able to do simulations over distance and also locally. And we find, again, that the clinicians use this technology themselves to practice before they have to do those procedures on real patients. What it's also done is it's opened up a career pathway for rural clinicians. So we now have a remote doctor who is the director of our entire MD program. She runs it 3,000 kilometres away from our main campus. So we've had democratisation of academic opportunity and academic recognition. What we've found is that learning in context prepares people better for practicing in context. So we are now in a situation where students actually don't have to come to the city to then go back to the country to learn or to practice. We can actually now enable them to stay in their remote areas right from the beginning of medical school and learn the entire curriculum. In many ways, what we've been doing is reinventing what some would call the apprenticeship system and enabling far more clinicians, particularly our rural and remote clinicians in primary care, to become teachers in the apprenticeship model. However, apprenticeship is often seen as a bad word since the Flexner Review, which, by the way, was 100 years ago now. And he quite rightly said that there were problems. There were problems with access to science, and there were problems with quality control. Now, IT have overcome those. You no longer have to worry about access to science because it's all here. So there is a democratization of knowledge of science that our students can access wherever they are. And by having IT-enabled assessments and evaluations, we've overcome the quality control issue as well. So in many ways, we've solved the issues that Flexner was so worried about and been able to return clinical education to its roots, to primary care, where the majority of care actually occurs. What we found in Dublin this week is that this sort of approach is even more applicable when you come to the developing world, where it enables a scaling up to meet the global need, which is 18 million more health workers by 2030. 18 million more health workers. We can't train all of those people in the large quaternary hospitals in our major cities. Firstly, there isn't the space. Secondly, it's not relevant to the work that the majority of them are going to do. Yes, we need some people learning in those environments because we need fantastic health professionals in those environments. And we need IT-enabled education to bridge the gap between the quaternary system and the primary care system and the secondary care system in between that, so that the whole of the health system becomes a learning organisation and benefits. If you want something interesting to read, there's a book called The Longitudinal Integrated Clerkships, Principles, Outcomes, Practical Tools and Future Directions. Anne Poncelet and David Hirsch have edited it. And Jay Rosenfield and I were asked to write the final chapter, which was on future visioning for this community-based clerkship. And we actually envisaged a future where potentially health services could regain, along with communities, the driver's seat in health professions education. That universities were seen as a partner and an adjunct, but they weren't actually in control. The control was vested in health services and communities across the world. And they partnered with organisations that had the integrity and authority to be able to give degrees and look at quality. But it wasn't actually driven from the centre, it was driven from the grassroots. The technology for this, and I'm happy to answer questions about that, it can be very simple, but it must be reliable. And as I said before, it must have inbuilt redundancy. If you do this, not only can it change you as an organisation, it can change your world and it can change the world of the people who you want to serve. I hope you've been able to hear me. I hope you've been able to understand my accent, and I look forward to questions and comments from the audience that I can see. Thank you.
Thank you, Paul. Perhaps we can do it in the following way, that you turn to your neighbors again, think 5 minutes of potential questions, and perhaps also of the opportunities that an approach such as Paul has presented can potentially be used also in your settings, and then we open up the floors and you can shoot questions and remarks at Paul. I'm happy to address those. 5 minutes discussion in the groups, and then we will be back here on the floor.